Good evening, everyone. Hello there. Let's see, we're trying to get everybody live here at the same time. Hello, America. Hey, it's Dr. Randy Fink here live in Pensacola, Florida, and this is Fertility with Fink and Friends. This is the place that you are supposed to be. Every Tuesday evening at this time, it's 5 o'clock on the Gulf Coast, which means 6 o'clock on the East and 4 o'clock in the mountains, 3 on the West Coast. And golly, we are here to talk about all those things that are important to us tonight. That's things about making a family, things about getting pregnant, staying pregnant, all those things about women's health, and gosh, everything else you want to know and want to talk about. Please throw your questions my way. And I am so happy to see everybody tonight. I hope, forgive me for being just a little bit not punctual this evening. We had a little bit of a late start, kind of a busy day over here in the office for me in Pensacola. I am a fertility gynecologist here at New Life Fertility in Pensacola, Florida. We have offices in Mobile, Alabama, and in Panama City. And I also work with the fine folks at the Missouri Center for Reproductive Medicine in St. Louis and in Tulsa. Great to see everybody tonight. I hope that your Memorial Day was a meaningful one. It was for me, and I have a special shout out to all of our veterans out there, especially to former Captain retired Harold Fink for your service in Vietnam and everything that you did for our country after that in the service of this great nation of ours. Happy Memorial Day to everyone. It was a rainy one over here on the Gulf Coast. It wasn't such a pretty day, but I have to say it's exciting times here in my house. I've got my oldest son is back visiting from college. My middle child, my second, actually I would say my youngest son, he is going to graduate from high school this week, tomorrow actually, which is extremely exciting. My daughter, who is my youngest child, she graduated from the 8th grade and is going on into high school next year. And so, gosh, all these exciting things happening over here, and I hope your summer is shaping up to be just as exciting. Gulf Coast is always an exciting place to be in the summertime with the white sand beaches and the beautiful weather and the beautiful water out there. So if you're ever thinking about coming to pay a visit, the summertime is a great time to be at the beach. Let's see who is joined. Hello, Katie Flores, and hi, Midgie. Hey, Daisy in Miami. Thank you for being here. It looks like the other Dixie Daney, I think that says. Dr. Williams, our illustrious and esteemed embryologist, has joined the program tonight, but he is trying to keep himself distant because I keep asking him to come on the show and to record some content with me, and he is always the ever elusive Dr. Williams. The Bama gal, my mama. Hello, mama and dada over there in Mobile, Alabama. And I hope you just heard the little shout out to dad. And I didn't even see that Max joined. Max is my oldest son, who I mentioned there. Rosa, you were the first one to join over here, and thank you for being my number one. Hi, JK, good to see you here this evening. Jen Hardwick is here with us on the Facebook side. So this is my Instagram right here, and that's Randy Fink MD. Feel free to follow me there. If you don't, please do. Would love to have you and educate you with some marvelous, entertaining content. We've got Facebook, we've got YouTube, we've got LinkedIn, we have MCRM, we have New Life Fertility, we have First Fertility Network right here in the middle, and we have New Life Fertility's Instagram right over here. Hi to Zaneta, good afternoon. Also in Miami, thank you for being here as always. Dara, nice to see you here. And looks like Savile Rich, I think is what that says. If you have a question for me tonight, please throw it out my way, because our job is to talk about all those things that are important. And that is the business about making families, the business about gynecology, the business about pregnancy and getting pregnant, and staying pregnant. It was kind of a little bit of a challenging day over here. We had a couple of folks come in and sadly have ultrasounds done that did not show ongoing pregnancies. And so, of course, the question that everyone asks is, why does that happen? Why does a miscarriage occur? And the answer is, in most cases, it happens as a result of the embryo itself. So it is said that in about 70 to 80% of the cases, the issue is considered to be largely chromosomal, meaning to say that, the sperm that comes out from the male today was manufactured in his body about 3 months ago. But every egg that the woman will ever have in her entire life is there from the moment she is born, from the day of birth. And so over the course of our lives, the DNA, the genetic material in those eggs starts to become less stable. And that results in eggs that just either can't be fertilized, or in eggs that are not normal. And when you fertilize such an egg, it will not continue to grow in most cases. And so, when we're working folks up, and there is a workup for recurrent pregnancy loss, there are things that we go to look for very specifically, because there are some absolutely treatable things that we can do for folks who have recurrent pregnancy loss, and potentially even for recurrent implantation failure. That is when we keep putting embryos back inside, but they don't stick. These are things that in some cases we can treat. We look and we look and we look. And, honestly, it is our job to look under every stone to make sure that we're not missing something. But we spend 90% of our time looking for 10% of the problem, because most of the time the issue really is about the embryo itself. When we test an embryo and we know that that embryo is chromosomally normal, it gives us, they say, about a 65% probability of pregnancy for most embryos, for a good quality euploid or chromosomally normal embryo. And that's a wonderful, wonderful thing, but 65% is not, unfortunately, 100%. When we test an embryo, we know that, at least we believe, that the chromosomes are normal. That testing of the embryo we do in IVF is called PGTA, pre-implantation genetic testing for aneuploidy. Aneuploidy, of course, means for abnormal cells. When our embryologists do this test, they are testing from the outside portion of the embryo. They're testing from the part of the embryo that's known as the trophectoderm. The trophectoderm is the part of the embryo that becomes the placenta. And so we know that when those chromosomes come back normal, we're saying that the placenta is normal. It is possible to have some discrepancy, a discordance between the placenta and the embryo itself. So 65% is not 100%, but even if we conclude, sure, the embryo is chromosomally normal, that doesn't say anything, unfortunately, about the millions of little chemical reactions taking place in every single moment inside that embryo. Because if one of those goes wrong, then the embryo may not continue to grow. The downstream effect of that abnormal reaction means that something may just go awry and the embryo doesn't continue to grow. Now, yes, there are maternal factors, and people are always worried. What is it about me? What is it about me that can't keep a pregnancy inside? Or is there something about me that can't keep that pregnancy inside? And the answer is, it's 10% of the problem. The largest, like I say, we spend 90% of our time looking for 10% of the problem, when most of the time it really results in an issue from the embryo itself. Nevertheless, that pregnancy loss is a heartbreaking time. This is a loss like quite literally any other member of your family. It may be a member of the family that you haven't gotten to know yet, but it is a member nevertheless, and part of that family of yours for whom you have hopes and dreams and aspirations and all kinds of love attached to, even though you haven't gotten to know them yet. So, losing a pregnancy at any point, even in the first trimester, is something that is very, very traumatic. In my opinion, I think it's especially cruel when folks go through IVF, or not even IVF, they go through fertility treatment in order to get pregnant, and they achieve that pregnancy. They get that positive pregnancy test, but then come to find that the pregnancy is not continuing. I really do think that's especially a heartbreaking scenario, and my heart goes out to those folks who we saw today in that situation. The good news is that, well, when you do get pregnant, even if that pregnancy is a what we'll call a biochemical pregnancy, which is where you get the positive pregnancy test, and then before you know it, the number goes on, but then it starts to go backwards if you're following it. Or it may just be you had that positive pregnancy test and you end up then getting a period. That's what's known as a biochemical pregnancy. Even in that scenario, what it's telling me is that at least the body knows what it's supposed to be doing. At least we know that the uterus has the ability to implant that embryo, and that the problem with it is that it's not able to continue to grow, and that's usually because of its programming. That's usually due to an issue with the genetics. So it's a step in the right direction. It's never something that we want, but if that cloud has to have a silver lining, it's that we know that the pregnancy can implant in the uterus, and we're a half a step closer to getting where we want to be. But again, thoughts going out today to all those who had a really tough day, kind of having an ultrasound and finding that there was no heartbeat. When we look and we see a heartbeat, we know that 95% of those pregnancies will continue on without having a problem, which is the best odds we can hope for. That is the day that we all celebrate, looking and seeing the heartbeat. 95% chance that that pregnancy continues. Jen asks, what about treatments for anovulation? Well, that is a very good question. So what does even that business mean? So normally under normal circumstances, the ovary releases an egg. And actually, let's take that back a step. Let's start at the beginning of the menstrual cycle. So let's say you're just having your period, cycle day 1. Well, at that point, the brain is telling the ovaries, give me some eggs. And the ovary says, okay. And so it dips down into its well and it pulls up a bunch of little what we call follicles. A follicle is quite literally a little sack of fluid that contains a microscopic egg in it. Those follicles, they sit in the ovary, and in fact, we can do an ultrasound where we look at those follicles. We can actually count the number of follicles. That's called an antral follicle count. And in my clinic, we do that because we want to know, what are we dealing with there in the ovary? Those eggs hang out with each other, and they quite literally start to fight with each other. They bicker, they pull each other's hair, they call each other names, they scratch each other, and they are fighting because one of them is trying to climb its way over the other ones to become what's known as the dominant follicle or the dominant egg. And that's the one that goes on to get released or to get ovulated. So when you release that egg, it's like a car leaving a garage. The ovary kind of acts like a little bit like a squirt gun. It goes, and it does actually make that noise if you listen very carefully. It squeezes that egg out. That egg gets taken up by the fallopian tube. Sperm swims in. Here's the visual. Sperm swims in, swims up into the fallopian tube, meets up with that egg in the fallopian tube. Ideally, the ideal situation is that the sperm is there waiting for the egg when it gets released. And so they meet one another in the fallopian tube. That's where fertilization takes place. And then that embryo works its way on down and implants inside the uterus. So that's the situation when things normally happen. Releasing that egg is, of course, ovulating. Anovulation is when you don't release the egg. And if you don't release the egg, you don't get the signal. And if you don't get the signal, you don't have a period. So those who have chronic anovulation may go for months and months without having a period at all until eventually they start to bleed, and then they bleed, and then they bleed, and then they just kind of keep on bleeding and bleeding and bleeding. Because they never got that right start and stop signal. And that's what's known as an anovulatory cycle or anovulatory bleeding. And we fix that by using some progesterone, by using Provera in most cases. And what that does is it kind of reboots the system. It's the same hormonal signal that the body would make if you released the egg, but then that egg didn't get fertilized. So when you release the egg, the space that's left behind is known as a corpus luteum. The corpus luteum is your own personal progesterone-making factory. And that progesterone is the hormone that goes on to support the pregnancy if the pregnancy has taken place. If there's no pregnancy there, then the corpus luteum starts to go away. Your progesterone level goes, it drops off, and that's the signal for the period. Now, when we give you progesterone, we're doing the same thing. You get some progesterone. It's as though you released an egg that didn't get fertilized. The progesterone level goes, and it does actually make that noise as well. And it goes down, and that's what triggers the period. I think of it as mowing the grass. That is when you get the real clean out. So that will stop that anovulatory bleeding situation. So what is the treatment for anovulation? Quite simply, it's just getting you to release the egg. How do we do that? Most of the time, what we use in the fertility world is letrozole. Letrozole is a medication typically you take for about 5 days that will speak to the brain and tell the brain to make more FSH hormone, which speaks to the ovaries and tells the ovaries to release the egg. Now, there are some people who are resistant to that medication, and it doesn't work so easily. And then we kind of have to step it up a notch. We might have to increase the dose. We might have to add some things in there. Some folks will use Clomid for ovulation induction. That's an older medication and one that we really very rarely kind of use in reproductive medicine. Now, many generalist OBGYNs will still reach for Clomid as first line, but particularly for those who are anovulatory, polycystic ovarian syndrome specifically, which now has a new name. It's a metabolic name that focuses on the metabolic aspect of that rather than just on what's happening in the ovaries. But letrozole is really probably a better choice in that scenario. And what it does, it causes a little blip in your own estrogen level. So your estrogen level drops a little bit, which tells the brain, make more estrogen. How does it make more estrogen? It makes more estrogen by telling the ovary, give me an egg, because your estrogen is made by the little cells that surround those eggs. So the treatment for anovulation is simply getting you to ovulate. Letrozole is really probably the best one for that. The reason I say Clomid is not as good a medication for that is because Clomid, what it does is that it tells the brain, stop making estrogen for a very short period of time. It shuts down all the estrogen. And one of the places that really needs that estrogen is the uterine lining. Because estrogen in the uterine lining is what makes a nice, spongy, warm, juicy place for a pregnancy to implant. And so Clomid can work against that. It can actually thin out that uterine lining and really work against the pregnancy. So it's another reason why really it is no longer kind of the first choice for ovulation induction. But good question there, Jen. Thank you for that. Appreciated. Let's see who else is joining. We've got Tracy. We've got Steph. Over here on my side, we've got Beth. Hi, Beth. Zenny says, nice shirt. Thank you very much. I appreciate that. Hi, Pooey. Good to see you, my friend. And again, I got to throw in, I just have to say it, one of the best sushi experiences you will ever have, any place, happens to be in the St. Louis area, and the place is called Sushi Station. Pui is the owner there, and she and her staff they're artists of the raw fish, I would say, artists of the Asian fusion cuisine. I am so impressed with you, Pui. Hi, Kara. Nice to see you, and thank you for following me. I appreciate that. Aj, hey, and Tara, good evening to you. Sharmilla, nice to see you, my friend. Sharmilla says, I have 7 M babies, PGTA normal. One that is my baby girl. I have 6 more left. So recently she got diagnosed with congenital bilateral ptosis. So do the remaining M babies also have this? And the answer is no, not necessarily. So ptosis, for those who don't know, is spelled Ptosis, like ptosis. Ptosis means dropping. So ptosis of the eyelids would be where basically kind of where you look sleepy, where your eyelids are kind of closed. Now my eyelids are open. In most cases, that ptosis is as a result of a muscular issue. And you're saying that it's congenital bilateral ptosis. And so that can sometimes be associated with certain hereditary syndromes. However, it can also more frequently occur as an isolated finding. And so the answer is no, that doesn't mean all your embryos have it. Now, I would certainly say if it turns out that she has some kind of syndrome, and usually a syndrome means when they have, let's call it 2 or 3 or 4 different things, like maybe she has some ptosis of the eyelids, and maybe the tip of the ear is a little pointed, and maybe the shape of the head is a little bit different, or there's something about her gait or something. That's what I mean by a syndrome. Oftentimes that collection of symptoms will have a name. And if it has a name, there is a possibility that they know its location on our chromosomes, the area that causes that, such that you can actually test the other babies, or the other embryos rather, to see if they are affected. But I will say that in certainly a large number of cases, I don't know if it's most cases, but that's my instinct. Ptosis as an isolated finding is just simply a little nerve and muscle issue in the lids, and it should not be something that is in the other embryos. Sharmilla, I know how stressful that is, because we never want to think of something being there that may hurt our children. And Sharmilla went through, all kinds of tough times in order to get your baby. And we are so happy for you that you have her. And hopefully they are helping you understand that there may be treatments that are available for her. Sometimes they wait a little bit until she's grown a little bit more, but often that is something that can be surgically addressed. Jody Hoffman, the wonderful and talented Jody Hoffman, is a nurse in Missouri who used to work with me in Colorado. She is one of the kindest and funniest people I know. Notwithstanding looks alone is enough to make you laugh at her. Did I just say that out loud? I meant to think it on the inside, but I guess it sort of slipped out there. But that's all right. Jody was probably around for a moment, and then she came and went and didn't hear me say that. So now nobody's going to tell her, right? Yeah, let's keep it that way. Rosa, hi Noodles. Noodles for Life is here, which is also one of my favorite names. Rosa asks, a day 7 high-level mosaic segmental embryo retrieved at age 42, is it transferable? And the answer is yes. So there's two things to consider there. The first is that it is a mosaic embryo, and it's what's known as a high-level mosaic. What is a mosaic embryo? The easy way to think about that is that, we have two sets of chromosomes, right? We have 46 chromosomes. I'm a 46XY. If you're a female, you're a 46XX. 46 pairs in the sex chromosome. So a mosaic embryo is where one set of embryos, it's a good way to think about it, one set of embryos has an abnormality in a portion of that chromosome. So it may not be the entire chromosome, it may not be the entire set of chromosomes, but rather a portion of them. A low-level mosaic means a smaller amount of that abnormality, whereas a high-level mosaic means a greater amount of that abnormality. Now, many people would think of mosaic embryos as potentially being normal embryos because in many cases, certainly not all, but in many cases, the mosaicism of the embryo can be corrected in the body. Our bodies have pretty good DNA repair mechanisms. And so if you place that mosaic embryo inside, the body may be able to fix it so that it results in an absolutely normal offspring. The problem is that it doesn't always work that way. So you put the embryo in, and it's not that it creates an abnormal baby, but with the mosaic embryo, there is a higher risk of miscarriage. And that's really kind of what we're talking about here. In most cases, these chromosomally abnormal embryos, if they implant, it's not that they go on to give you a chromosomally abnormal baby. It's just simply they stop growing. Either they don't implant at all, or most of the time they will just stop growing. So one of those two things, or really one of those three things, or it could, absolutely could continue to grow and correct itself and be normal. But then the other thing that may be working against it is the fact that it's day 7. Now, a day 7 embryo means that, that means it's a blastocyst. Typically, a blastocyst becomes a blastocyst on about day 5. And if it's made it to day 7 before it becomes a blast, that means it's just moved a little bit more slowly. It's taken a little bit longer to reach that metabolic milestone. And as a result, we think that, gosh, that embryo, it may not do as well. And so when you transfer a day 7 embryo, we're talking about a lower probability of pregnancy. So let's say that you have a day 5 blast that you test, you do the PGT testing on, and it is a euploid or chromosomally normal embryo. That embryo gives you a 65% probability of pregnancy. If it is a day 7 euploid embryo, if it's a good graded embryo, that embryo, apples to apples, gets you roughly about a 20 to 35%, we'll say the range there, probability of pregnancy. So just because it was a slower moving embryo, it took it 7 days to become a day 5 embryo. That's another way to think about that. It may not function as well. So Rosa, the question is, is it transferable? Can you put that embryo in you? Yes. Have I seen day 7 embryos give you absolutely normal babies? And the answer to that is all the time. So you don't discount an embryo, in my opinion, just because it's a day 7 embryo. Different people have different opinions on that. But yes, they absolutely can work. I have held those babies in my arms, and they are beautiful, nice, normal, wonderful babies like any other. But what we think about is, well, what is the statistic? What are the odds? What are the chances that it's going to give you a pregnancy, and a pregnancy that's ongoing? The fact that it's mosaic means that you're at a little bit of a disadvantage. You have a higher risk of non-implantation and a higher risk of miscarriage. And the fact that it's day 7 also means that there is a higher risk of it not sticking. So is it transferable? Yes. Could it work? Absolutely. But let's just say it's not as strong an embryo as it would be if it were a day 5 mosaic, or for that matter, a day 5 euploid. So I hope that makes some sense. Oh my gosh, a special shout out to Patricia Davis. It's good to see you here, my friend, if you are still around. Thank you for being here. All right, so we're 30 minutes on the air here tonight at Fertility with Fink and Friends, and that means it is time for the 5:30 Fuzzies with Fink. Dong dong, fuzzies for Fink, fuzzies not for Fink, fuzzies with Fink. What does that mean? And it's actually 38 minutes past the hour, but since we were a little bit late starting, I feel like we have the leeway to do this. The fertility business here is a very challenging one for everybody who has to go through it. It is a difficult time indeed. It is something that creates fear, it creates stress and anxiety, and it can create really intense feelings of loneliness and despair. And feeling despaired feeds that loneliness and really makes you think that you may be the only one who is really getting ground down here by this process. The Fuzzies with Fink at half past the hour is our opportunity for us all to stand together as one community and send out the positive vibes to everybody tonight who needs them. And it's not just about fertility. It's about relationships. It's about school. It's about jobs. It's about family. It's about all those things in our world that make our world difficult day in and day out. You know, we're not around on this planet for really all that long, relatively speaking, and sometimes it's really hard to see the upside of being here. Well, I'm here to tell you tonight, folks, that every single one of you has touched someone's life in such a way that their lives will never be the same. And that is a gift. It's a gift to you, having been able to do that, but what a gift that is to them. So when you're lonely and when you're frightened and when you're scared and when you think that there may not be an easy answer, I want you to think about it this way. I think we're all here for a reason. And as we stand together tonight, let's share the good vibes in that reason so that each and every person out there knows that they are valuable, not just to someone, but really to everyone. We all have our place in this world, and this is our opportunity to break the internet with kindness and send out those positive vibes. If you're hurting tonight, we're all here with you. You are not alone. As I'm fond of saying at the end of the program, tomorrow is a new day, and it's full of all new adventures. So let's look forward to tomorrow. And that, my friends, is the 5:30 Fuzzies with Fink. Thanks for being here for that part. Stick around. We got another, half hour or so here talking about questions, things on your mind. So let's jump right back to it. By the way, if you're just joining, I am live tonight from Pensacola, Florida, where I am at New Life Fertility. We also have offices in Mobile and in Panama City. I work also at the Missouri Center for Reproductive Medicine in St. Louis and in Tulsa. Please pick up the phone. Please point your way on the internet. We're happy to talk to you about your cycle, no matter where you're doing your fertility treatments. Happy to give you an opinion and try to help you through. We'd love to see you at our place, but understand everybody can't do that. Still, you're not alone in this, and we're only too happy to help. So happy to be there for you. Hi, Amal. Nice to see you this evening. Amal says, my progesterone was 7.5 during transfer last Thursday. I went for a progesterone test today, and it's at 40. Does that mean I have a chance of getting pregnant? So what's happening there? So as we know, there are two types of embryo transfers. One type is where we give you the medication to mimic what your body would naturally do. We give you a bunch of estrogen in the form of either a pill or a patch, and we give you progesterone as though your body was making it. And then you place the embryo inside, typically 120 hours of progesterone, then you get your embryo transfer. That's a medicated cycle, or what we call a programmed cycle. A natural cycle is where we want you to ovulate. We want your ovary to release the egg, because remember what we called it? The corpus luteum. The corpus luteum is the area in the ovary when the egg leaves. It leaves behind that space that becomes, like I said, it is your progesterone factory. So if you ovulate on your own, you're making your own progesterone. Well, we check those progesterone levels. And I would say, Amal, that a 7.5 is a little lower than what I would like to see it. Now, in nature, those progesterone levels, anything above a 3 means that you ovulated, means that the egg was released and that you are making that progesterone on your own. Well, in a natural cycle, we like to see, progesterone levels being at about a 10. And in fact, even in a medicated cycle here, I use a 10. 10 to 15 is kind of a good number. So my guess, Amal, is that you had a little bit of a low number, and so they probably increased your progesterone, or if you weren't on it, they probably started you on it, I think is probably what happened there. And as a result, now you have a great progesterone level, and the answer to that is yes. That means you absolutely could be pregnant. Absolutely, because the key is identifying it. You identified that progesterone level was a little lower than optimal, which means that we could increase the amount of progesterone that you're getting so that it fed that lining, it fed that, hopefully, that ongoing pregnancy. So fingers crossed there, Amal. Absolutely. Those are exciting times. We can't wait to hear what happens next week, and hopefully it's a positive test. Jen says, I'll be connecting through telehealth with Panama City in 2 weeks. And that is wonderful. We will look forward to that. We do telemedicine visits all the time. You don't have to come in. So those are the kinds of things you can sit in the privacy and comfort of your own home, your car, your office, and talk to us about the things going on in your world. Let's see what we can do to help you get a baby. Marlena says, I hope you had a great Memorial Day weekend. Thank you, Marlena B. I appreciate that very much. Danessa and Depino Journey, nice to see you here tonight. Audrey Kristen, thank you for being here. And let's see what else. I got some more coming down here. Let's see, Sharmila, just to follow up on the ptosis, it is on the muscle, yep, and she needs surgery. And you're seeing the ophthalmologist. Yep, so you are doing absolutely the right thing, and that's fixable. So good, I'm happy to hear that. Beth is here, who unfortunately suffered a second loss and found out today. Gosh, Beth, I am so sorry to hear that. The FET resulted in a biochemical pregnancy. You were on an immune protocol and an antihistamine protocol. First FET ended in a miscarriage at 9 weeks in 2024. Both embryos were PGTA normal. Where do I go from here? And Beth is a single mother by choice. So, gosh, it is a very hard. So, our hearts go out to you tonight, obviously. Both of these suggest that there's likely an embryo issue, although losing the pregnancy at 9 weeks means to me that, well, presumably prior to that point, you saw an ultrasound and saw a heartbeat. So when that heartbeat is there and that heartbeat stops, it starts making me think that, gosh, could there be something else that's going on here? So the biochemical pregnancy is almost always an implantation issue. It's almost always a situation of the pregnancy kind of grabbing a hold and then realizing something is not right and therefore is not able to continue. Excuse me. So, what I would do in that situation is that, I think it's worthwhile to start looking under some stones, really, for sure. And so there are some blood tests that we do that look for certain types of things in the body that are associated with clotting issues. There is something that's called a lupus anticoagulant. There is something that's called an anti-beta 2 microglobulin or microglobin antibody. There is something that is called a Russell Viper venom test. There is something that is also called the an anticardiolipin antibody. And what these things are things in your body that make the body want to form clots in the small blood vessels that supply things like the placenta. Those are the recommended tests that come from the American Society for Reproductive Medicine to evaluate recurrent pregnancy loss. And having lost 2 euploid embryos, that certainly warrants the evaluation. I would check those blood tests. I would check a couple of autoimmune things. I would look at your ANA, which is known as an anti-nuclear antibody. I would look at your anti-thyroid antibodies, because those 2 things kind of give us a clue as to, well, what's going on with your immune system in general. So we can make sure that we're covering the right bases. Certainly on a future transfer, I would use the medication known as tacrolimus or Prograf, which is really the best studied immune intervention for folks with recurrent pregnancy losses or implantation failure. And lastly, for sure, I'd want to take a look inside your uterus. I'd want to put a little camera in, take a look. Let's make sure that there's no scar tissue. Let's make sure that there's no chronic inflammation in that uterine lining, something that may be making that environment inhospitable to your embryos. That's kind of the basic work up there, Beth. But gosh, I think the most important thing right now is to tend to your heart. Because having to undergo this really a second time, like I said, I think it's probably one of the crueler aspects of what life throws at us, going through fertility treatment to get that positive pregnancy test, only to then find that the pregnancy doesn't continue to grow. Thoughts and prayers with you tonight, Beth. Jen over here on Facebook even says, so sorry, Beth. Hi, Kristen. Thank you for being here this evening. Kowser, hello, my friend. Thank you for joining us. Let's see. Oh, gosh. Beth says a couple more things. And actually, Marlena says, yeah, so sorry, Beth. Did you suppress before transferring? And actually, endometriosis may be another thing. Oh, and actually, you have said here you have 2 embryos left, a day 7 and a low-level mosaic. Neither of those are throwaway embryos. Very important. Do I do another lap excision? I had one in July of 2024. Stage 2 endometriosis was removed. Do I do suppression? So my answer to that, and this loss was a day 6 PGTA normal embryo. The last was a day 5 PGTA normal. My answer to that is 100% yes, that you would want to suppress endometriosis for 60 days before putting an embryo inside. Why is that? Because you know that you've got endometriosis. We know it's there. right? Now, endometriosis more commonly will block the implantation of the pregnancy. So you keep putting embryos in and you don't get pregnant. But can it result in recurrent pregnancy losses? In theory, yes, it can, because again, what it's doing is that it's blocking your progesterone. 60 days of suppression, that's using Orilissa or Myfembree, the oral medications, or 60 days of Lupron, sometimes even adding letrozole to that. Will reverse that process at the level of the endometrium, at the level of the uterine lining, and I do think that's important. So in my practice, if I had known about that endometriosis beforehand, I probably would not have put your day 6 euploid embryo in without suppressing. Why not? You're taking a risk. You're just taking a risk. Now, was that the cause of your pregnancy loss? We can't say that because, and we're really never going to know that for sure. But I would say, why risk it for 60 days of popping a pill? You get some hot flashes from it. It's not, it's not a joy to the world to be taking that medication, but in order to be able to get an ongoing pregnancy, 100%, I would suppress before doing another transfer. Yeah. And Beth is 41, so she says the clock is ticking. But you've got the embryos, and that's the important part. You've got embryos. You could always get more embryos because remember, your uterus is not going to age at the same rate that your ovaries do. So the key factor is getting the embryos, or getting the eggs, making the embryos, having those embryos, and you can put them back at any time. So, but you still have a day 7 and you still have a low level mosaic. Those are not throwaway embryos. And again, our thoughts and prayers are with you. We will absolutely keep our fingers crossed there. And Beth says, I did not do Depolupron because the long-term side effects worried me. Well, I'll tell you there, Beth, and don't beat yourself up over it because what's done is done. Be gentle with yourself here. But you're not going to be on Lupron for long-term or Orilissa. You're going to be on it for 60 days. Now, people who have significant endometriosis, let's say you're debilitated by pain, we can use these medications, right? We can use these medications and we can treat you with Lupron for 6 months and then repeat another 6 months. Gosh, with Orilissa, you can take that for up to 2 years. And yeah, those things really can potentially have some long-term side effects. But for 2 months, I absolutely think it's safe. And I think that the benefit outweighs any risk because that short-term treatment, not the same as the long-term. Hi, Logan. Good evening. Yes, it was Fuzzies with Fink time. And thank you for being here. One of the finest therapists in Arkansas, let's say in Northwest Arkansas. I always appreciate it when you join and share with us. Thank you. Let's see. Beth, by the way, is asking if anybody has had experiences with Lupron or the other suppression. I've been using the Lupron Lupron was all we had for about, probably 25 or 30 years. So I've been using it for a long time. But Beth's handle here is Beth TMT. Beth TMT. That's Tango Mike Tango 824, Beth TMT 824. And I hope you don't mind me calling attention to that. But if you have had experience with Lupron or with Orilissa, please, why don't you message Beth so that she can feel a little more comfortable with the idea and certainly not as alone tonight because Beth, today was a hard day for you. Again, that's Beth TMT, BETH Tango Mike Tango 824. Why not drop her a message? Ileana McRoberts, good evening. I had 3 very early miscarriages. Do you have any suggestion or advice moving forward with treatments? So, again, Ileana, most of our pregnancy losses occur as a result of chromosomal issues. When we do IVF with pre-implantation genetic testing, or PGTA, we are able to create embryos and test those embryos so that we know which of the embryos are chromosomally normal when we're placing that embryo back inside. And when we do that, we are literally removing the reason for 70 to 80% of all the miscarriages. So that's the first thing that I think of. If you are trying on your own, gosh, I wish that there was some intervention that we had that was really known to make a difference kind of in the general population. But unfortunately, there really isn't. I think, Jessica, it's worth doing some testing. I think it's worth looking into some things with some blood tests, certainly looking at the uterine cavity like we talked about there, potentially looking for endometriosis to see if any of these things contributed to those 3 early losses. And gosh, you know, having that happen to you 3 times is a tough one. That is a tough pill to swallow. Yeah, indeed. Kauser says, is dry mucus during TWW normal? I have a little left side pinching pain too. TWW. I think I'm not sure what TWW means. Maybe I'm not in the know. Maybe I should spend more time on TikTok because I'm sure it's on TikTok. But TWW, I'm thinking it has something to do with maybe like timed intercourse. Dry mucus, the cervical mucus, you know, changes over the course of the menstrual cycle. So right around the time that you ovulate, that mucus becomes a lot more watery. And it actually, there's a term for it. The term is called spinbarkite. So if you took that mucus, you could stretch it out through your fingers, and you're probably going, ew, that's so gross. Yeah, you know, it is what it is. But during the other times of the cycle, so in the beginning of the cycle, that mucus is really very thick and really kind of very dry. During ovulation, the job of that mucus is to basically grab sperm and pull it up to the inside so it's able to make it to the inside of the uterine cavity. And the left side pinching pain, you know, I think it may have to do with, you know, it can have to do with some anatomic things. It can have to do with some, you know, kind of vaginal dryness in general. And certainly I think, you know, the other thing that really comes to play here is that if we're talking about spontaneous conception and having intercourse, just in general. And when we're having intercourse at home with our partners in order to try to get pregnant, and this may not be, Kauser, the case at all with you, so forgive me, but it makes me want to say it. We can really, you know, get hung up in the brain. And when you're hung up in the brain, and you're thinking about the calendar, and you're thinking about having to get sperm there, and you're thinking about having to have intercourse because you have to get sperm there, because you have to get pregnant, that can really take a lot of the joy out of that intimate relationship with the partner. It really can, do a number on you. For men, it causes a very obvious problem. It can cause erectile dysfunction. It has to do with the sympathetic nervous system kind of getting in the way. And in women, is the same situation. When the sympathetic nervous system starts to get in the way, it can stand in the way of normal lubrication, because vaginal lubrication with arousal is the process of the engorgement of the blood vessels that surround the vagina and what's called a transudate of the serum fluid across the epithelial cells or across the skin of the vagina. And if the brain is working overtime thinking about it, that will cause issues with vaginal dryness. And it may be that if you're dealing with that kind of dryness, along with the mucus at ovulation time, it may actually seem a lot less moist and a lot less sticky. So that's certainly a possibility. Hello, Pensacola Wellness. Marlena says, I haven't transferred yet, but I'm currently suppressing on Oralissa with Dr. Fink. I've heard a lot of success stories where people had failed transfers, then suppressed with letrozole, plus or minus Lupron, and had a successful transfer after. Yep, and I hope you're sharing that there with Beth. Yeah, no, I honestly, I see it every day. I use a lot of that medication in my practice because, we really, now that we've been able to identify what actually endometriosis does on a cellular level, then we find that it really stands in the way a lot of times, particularly as it pertains to things about doing embryo transfers. Now, it's less clear how much that stands in the way with spontaneous conception. So many people say, well, gosh, I mean, I want to do that non-invasive test for endometriosis, find out if I have it. If I have it, I want to suppress, and then I just kind of want to keep trying on my own. And I'd say you certainly can do that, but we just don't really know what that means. We don't know about what doing that suppression, how it affects spontaneous conception, because the data is really there from taking chromosomally normal embryos and putting them in the endometrium and knowing what the expected performance is versus what the actual performance is in the face of that marker, which is called BCL6. And that's what endometriosis does. The problem there is that you're putting sperm, you're putting, let's call it a minimum of 20 million sperm, right? 20 million sperm is what we say is a normal sperm count for intercourse at home. You're putting 20 million sperm inside the vagina. Some of that sperm is not going to make it up to the inside because they're not strong enough. They're not good enough swimmers. And that's kind of one of the reasons it's taken out some of the less good sperm. But that nice cervical mucus is going to grab that sperm and pull it up into the inside, and it's going to swim its way into the fallopian tube. But it still has to shake hands with an egg. And we know that just doesn't happen every time. So there's so much chance that's still involved with spontaneous conception. That's the reason that they can't really say, that it's really very hard. There can be so many other factors involved that it's very difficult to reach conclusions about how doing things like suppression with suppression with home intercourse, what kind of outcomes we can expect from that. Hi, Lelix, it looks like. And let's see what else we have going on here. Natera. Okay, we're talking, there's a little bit about Natera. This is Beth throwing in that. Natera is one of the brands of what we call the genetic carrier screening tests. And the carrier screening test looks to see if you are a carrier of any one of about, well, actually, there's about 1,200 of them that they've identified. We don't recommend that you do a full 1,200 disease test because most of us are carriers of something on our chromosomes. Most of us are. And so the more things that you test for, the more likely you are to get a positive. And then when you get a positive, what happens is that your partner has to test. And what we're looking for is to see if you are both carriers of the same thing. Because if you're both carriers of the same thing, it gives you a 1 in 4 chance of having an affected baby. And the time to find out about that is really before you get pregnant, especially if you're doing something like IVF, because we can prevent you from having an affected baby. We can test for embryos that are affected by that disease. The panel that we use here is 250 different genetic diseases. 250. And these are the most lethal. These are the worst. These are the most significant of the genetic diseases, because some of these things, when you test for 1,200 of them, some of them really may not be all that significant. They may be something like, single eye partial color blindness. Well, okay, it's very interesting that they've been able to isolate that on a chromosome, but do you really need to know that? Would you really do genetic testing on an embryo to prevent that from happening? Probably not. You want something that's going to prevent some terrible disease that's going to affect your child, or potentially, keep your child from being able to have a nice, long, and normal life. So that's what that carrier screening is, and it is highly, highly recommended. I very strongly recommend it. A lot of times folks will choose not to do it because they're concerned about the cost. Insurance does cover these tests most of the time, but insurance being what it is, a lot of times insurance will say, well, this is a very expensive, highly complex genetic test, and you have a big deductible. Maybe you've got a $5,000 deductible and then an 80% or 20% co-insurance. And so, the lab that runs this highly complex genetic test may charge the insurance company $8,000, and you may end up with, a $2,500 deductible or $2,500 payment or something. The Natera test that we use has a maximum out-of-pocket expense of $249. So even if it's going to cost more than that through your insurance, that's the most you'll ever have to pay, $249. So I do think it's worth doing if you're trying to get pregnant. I think that is a very important thing to know. How does, I think we got time for, Jamie Marie Newton is saying, currently holding my baby from an egg you retrieved in Colorado in 2024. Jamie, that makes me so happy. I love it. I love it, love it, love it. Thank you very, very much for sharing. Kelsey asks, how does endometriosis limit or inhibit embryo growth if it's outside the uterus? I had an excision surgery 10 months ago and the embryo implanted but stopped growing. It creates a marker in the uterine lining that's known as BCL6. Now, you could test for that, but I don't necessarily recommend it because you're known to have endometriosis. So, Kelsey, even though you had excision surgery 10 months ago, I would still absolutely do 60 days of suppression before putting another embryo in, because again, why take the chance? We think that surgery or suppression probably gives you about 6 months of effect there. And so by 10 months, I'd say, yeah, gosh, I'd feel so much more comfortable if you did suppression before using that next beautiful embryo. Gosh, folks, we're going to be out of time tonight. I'm sorry I got started a little bit late, but we got to run a little bit late here. And thanks, everybody, for sticking around this long. Every Tuesday evening, we're back in the same place here. And that is Randy Fink MD on Instagram. We've got New Life Fertility on Instagram. We've got New Life Fertility, Facebook, LinkedIn, YouTube, MCRM Fertility, the First Fertility Network, right here for Fertility with Fink and Friends. This fertility business is not the book of your life. It is just a chapter. And what are we here to do? We are here to rewrite it together. So every step forward with love, every step forward with kindness, and every step forward knowing there is hope for tomorrow. Tomorrow is a new day, and it's full of all new adventures. So until next week, I'm Dr. Randy Fink in Pensacola. Thanks so much for being here, and good night.